some aortic valve abnormal, only aortic valve, and some of them will have combinations, and like 2 to 3 people, they didn't have any pathology. And they found out there was significant delay because just by asking for echo, they won't come in time, postpone. So there was a delay from 1 day to 2.5 days. And you know that nowadays, even a 1-day delay is going to have a significant cost effect. So they proposed that appropriate time to ask for echo and as well as try to minimize it. So this is like institutional practice rather than following the guidelines. They have their own experience-based approach. So that's the experience and some guidelines. The final part of my talk is the future trend, and it has been happening in some of the parts of the UK, and it's widely practiced in Australia. It's just coming up in US, something called the focus echo by anesthesiologists in the preoperative clinic. And we have various abbreviations. The FATE, which is something called focus assessment thoracic echo, and heart is kind of hemodynamic echocardic assessment in real time, and that's the thing they use. And you can see even in TE, it took so many years for the evolution to convince and become like a standard of practice. So we are going to see, like maybe after 5 years and 10 years, the TTE by anesthesiologists in the preoperative clinic, it's going to be a big time. So, and the problem which in most of these medical legal issues we're facing is, okay, suppose if I do and say, oh, this patient is good or bad, you can do or you do modify it. But there should be, I need to take a responsibility and properly document. If I am doing echo and I am doing the case, that's fine. You're already included and you are like, involved with the case. But if I do the echo and then somebody else is do that, then it's the problem. Sorry about that. Just take a couple of minutes. And then in terms of ASC, they propose some protocol, what is called for focused cardiac ultrasound, and then you need to have appropriate acquisition, documentation, and this thing is going on. It's just published like a month ago, and keep revising, and then again it is not wide accepted. We need to convince the cardiologist. And one thing we need to remember, we are not replacing the cardiologist. Our aim is to do focused hemodynamic echo, and then how useful for our intraoperative practice. This is the brief retrospective review which was done in Australia, and few indications they choose for the echo by the anesthesiologist, and they encounter like some case cancellation and some interesting findings by just doing the focused echo. And most of them will have high degree of specificity. That's a good thing about this tool. And obviously they cancel few cases, before even asking the cardiologist. That's going to delay for a week or 2, rather than you just do it and you decide this is the thing. To summarize, we had just the role of echo in our evaluation and guidelines across the globe, and how we are implementing in practice. And some institutions, they have their own experience-based approach. And we also saw that how difficult to analyze such a common tool. We think that we have been using for more than 4 or 5 decades. So everybody thinks that echo is easy, but we couldn't find any proper study how we can analyze it, and future trend, and hope even we can collaborate with our cardiac society in India and to establish this program soon. Thank you for your patient listening.
Good morning, sir. A nice presentation. So recently we had one patient with ejection fraction 46%. Patient diabetic and hypertensive with HbA1c of 9.1. His previous 2-3 days or 1 week prior this one blood sugar this one reports were very high, and subsequently the day prior to the pre-op evaluation patient was sent. They were within this one because it may be after giving insulin, I don't know. Mixtard was the insulin, and patient was on glimepiride, pioglitazone, and metformin. Okay, and Q wave in the inferior wall this infarction suggestive for this one 2-3 AVF, and STT changes were also seen in chest leads. And the cardiologist had done echo about 6 months back. Ejection fraction 46%. So we advised cardiology reference and this one conversion to actrapid so that blood sugar can be properly this one, and stop this one OH, especially metformin and other this one sulfonylureas which can affect the this one, which can lead to hypoglycemia or other problems, or because of metformin, this one, lactic acidosis. That was the one. And because blood sugar was normal, the surgeons wanted to operate. It was about 2.5 for this one procedure. So I advised better I should have all this one, and so that we can. And the cardiologist was little bit reluctant to do this one. What is your opinion with this?
So you said the echo was 6 months back.
Yeah.
And
So-
then that is the evidence of some infarct, right? Old infarct, you said?
No, this one recently ECG was taken. And we don't know, at that time we were not getting, definitely the duration, more than 6 months or this, what you are stressing, I can come to this one, that was not available.
So you don't know what was the echo?
What was this one, ECG finding about 6 months back. Q wave seen, definitely there was an infarction. There's no doubt about this one. And obvious, this ones.
I mean, sorry, what was the procedure? I missed that part.
The lumbar hernia, they were telling, a patient was previously operated, then there was a patient had a fall, and this one's.
So they scheduled like 2.5 hours for.
Yeah, that was discussed.
And
And
it's
ultimately I concluded the patient has to be reviewed again by the cardiologist and if on this one. The necessary things what I told, conversion to actrapid and maintaining this one, maintaining BP chart, and this one.
I mean, I agree. Now, see, like you are adding so many things, diabetic part,
Yeah.
and the surgeon concern only like once you fix the
Yeah.
sugar, you're fine.
Yeah,
But
yeah.
as I mentioned, that we need to make individual decisions.
Yeah.
So what was the current clinical status?
Yes,
Right.
sir. Hmm.
So when
No.
you see any evidence of failure in our clinical assessment before
Cli-
even we send to the cardiologist. So that's
No.
why we ask, right? You saw that retrospective review on focused echo. Even they don't do just like that.
Yeah.
So they always go for clinical first. Yeah.
Yeah,
So, I mean, the thing is, you don't know about the 6 months back echo status by looking at only the EKG. That's just shows only old
no,
infarct.
6 months back is this one echo he had done, it was showing 46%. I am stressing. Ejection fraction
Yeah, so
46%,
okay.
mild to moderate diastolic dysfunction.
I agree. But is there any mention about regional wall motion rather than looking at the global function?
I don't remember.
That's the thing we need to pay.
Yeah,
because
regional, yeah,
The new regional wall motion can happen. It have been happening for last 6 months.
yeah.
And then was there any change in the previous EKG to current EKG?
No, yeah, this one, that was not possible to this one judge. That's what. Okay, okay. Thank you.
Sorry.
One more question.
Good morning, Dr. Sudhakar. Excellent presentation. Little audibility was a little low, but I have a very simple question, sir, regarding the role of echo. I am an anesthesiologist in the army. Mostly I use preoperative echo evaluation for my TKR patient, total knee replacement. I sent to the cardiologist for echo and the thing. I normally take criteria if below ejection factor is 45. I really try to avoid the case. But you have mentioned 35%. What's your opinion,
So
sir?
most of the, definitely less than 30, like we all know, it's going
So,
to have a bad outcome. But so, I don't know why you are like.
Under spinal or epidural I give. Will it be okay if the ejection fraction is 30 and still I take up a case? A TKR, it is not an emergency.
See, that's
What is your opinion, sir?
Sorry about that. So only you cannot look one factor, right? I mean, just mentioning about what was the cause for the low EF. Was there any associated valve problems? We need to see.
Okay, if the valves are not involved and only ejection fraction is 30, would you like to take up under spinal or epidural for TKR? A 60 or 70-year-old gentleman?
No, I mean, see, even if you do spinal or epidural, you are going to fix the problem temporarily, it's fine. But your focus is where patient is going to be in the post-op. You can still do, as long as you're comfortable with your techniques, we have done like many cases with bad diabetics who come for, even for the gelatin amputations, 45 minutes procedure. We don't know what is the EF. They will be very bad infected and we cannot delay those kind of cases. But yours is a pure elective and you still have a time to optimize. And now we have to execute whether medically optimized or whether they need revascularization. And I know most of the situations it's very, very difficult, but your focus is on, you can manage intraoperatively, but your primary thing you need to pay attention for post-op.
Thank you, sir.
Thank you, Sudha.
Thanks. Sorry about the audio issue.
We'll go to the next topic. Dr. Lily. It's a very good topic, especially for pediatric anesthesiologists. We welcome Dr. Lejit Shekhar, consultant anesthesiologist, Royal Hospital, UK.
What do you have to